Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today, helping to create a better tomorrow. Today, we have the honor of being joined by Dr. Andrea Meyer, who is the Unchu Sang Professor in Medicine, Healthy Aging, and Dementia Research, and co-director of the new Center for Healthy Longevity at the National University of Singapore. Professor Maier also holds professorship appointments at the Free University Medical Center in Amsterdam, Netherlands, and University of Melbourne in Australia, as well as serving as Director of Medicine and Community Care at the Royal Melbourne Hospital. In addition to all of that, Professor Maier is also the president of the Australia and New Zealand Society for Sarcopenia and Frailty Research, as well as founding president of the new Healthy Longevity Medicine Society. A fellow of the Royal Australasian College of Physicians, Professor Maier graduated in medicine from the University of Lübeck in Germany, was registered in the Netherlands as a specialist in internal medicine, geriatric specialty, and was appointed full professor of gerontology at the University of Amsterdam, where she was the head of geriatrics at the medical center from 2012 to 2016. From 2016 to early 2021, Professor Maier served as Divisional Director of Medicine and Community Care at Royal Melbourne Hospital, Australia, and as Professor of Medicine and Aged Care at University of Melbourne. Her research focus is quite broad, focuses on unraveling mechanisms of aging and age-related diseases. And during the last 10 years, she has conducted multiple international observational cohort studies and intervention trials. She has published literally hundreds of peer-reviewed articles on these topics and is a frequent guest on radio and television programs serving to disseminate aging research and an invited member to many international academic and health policy committees, including the World Health Organization. And she also serves as an elected member of the Royal Holland Society of Sciences and Humanities. We have a lot of interesting things to get into with her today. Professor Andrea Meyer, thank you so much for taking time to come on the show today.
Thank you for having me. That was a very long introduction.
You've done a lot. I could have gone on, but I think a great place to start actually would be to hear some of it from you, sort of the beginning of all this. If you could sort of take us back to the early days, everything from where you grew up, what got you interested in medicine and gerontology, and a little bit of this early career passion for this space. I'd love to hear that part of the story.
Yeah. I have a German passport. I live in the Netherlands and in Singapore at the moment. And I think if you ask where is home and where did you grow up, really, that's in Germany. In a village with more cows than inhabitants. So quite rural, that's a translation. Where it was quite difficult to follow passion in terms of arts, etc., because it was so rural. So at a certain point, my parents decided, okay, she has to go abroad, etc. So I did that from early ages. Went to different schools in America and everywhere to learn English. As a German, it's very hard always. Germans are not good at languages. So I grew up very rural and then went abroad and studied medicine, first in Halle, then in Lübeck, and then went to the Netherlands and went to a couple of different countries to actually see how our countries serve medicine and what they do. And I always had the intention to learn much more about culture and the cultural differences. That's the reason why I really love to travel. But I think if you look really at my genetic makeup, both my parents were in the medical field. So I grew up in a practice of my father and mother. My father at that moment in time was a GP and then became a dermatologist, but I was surrounded always, not only by patients, but also by lots of diseases. And I knew very early that would be my passion next to art. Of course, I had to decide, do I study art or do I go into medicine? At a certain point, my parents, especially my father, said, where do you get your money from? We are not going to do that. So you have to do something seriously. And so I studied medicine.
Excellent. Excellent. And you know, Andrea, as I mentioned in the your extensive bio, sort of at the very end there, you know, I mentioned one of the you know, responsibilities that you've recently taken on, aside from everything else that you're doing, you know, is basically as the president of this new Healthy Longevity Medicine Society. And if I may just read sort of, it's an organization committed to centralizing, establishing, facilitating, and promoting a clinical research agenda that encompasses all aspects of longevity medicine. And I really found this very refreshing and interesting in the sense that, you know, the last couple of decades, we've seen the maturation of things going on in the longevity biospace. We obviously see a lot of work happening at the bench in terms of our mice and our rats and our rabbits and dogs and so forth. We see the beginning of some interesting interventions into clinical development for novel drug products, but then sort of this third area that we don't normally talk as much about, but is extremely important. Just the world of medicine, that we do have a world here of 8 billion people. We have hundreds of millions of people alone here in the United States, age 60 and older. And medicine is practiced on a daily basis. And there are other things to do in taking care of these patients, as you well know, where we don't have to wait 20 years for the next wonder drug to come along. Can you talk a little bit about sort of just the principle of how you look at longevity medicine, in essence, what longevity medicine means to you, and a little bit about what the mission of this society is all about in promoting sort of this third leg of geroscience development?
Yeah, a big question. So first of all, let's start why I at the moment at a certain time said, okay, we need a society, we need a structure, we need something regulating something, because I was a hospital manager, especially in Australia, in Melbourne, but I was also a hospital manager or department manager in the Netherlands. And at a certain time, I said, okay, we are providing this care, and it's super care, and every year we have another drug, but essentially we do not change anymore. It's even better care every time, but I still see patients when it's a little bit too late. And there geroscience kicks in with the entire idea that the disease progression already starts after development. Even we are arguing if it occurs during development, but at least we can very easily measure from the 20th, 30th birthday onwards that we are declining in terms of function, and that the risk of an age-related diseases is occurring and it's accumulating. And why should I therewith, as a physician, as an internal medicine physician and geriatrician, wait until it occurs? And why should I wait as a manager that somebody knocks on my door 20 years later before we could already see disease progression and could prevent that decline and that occurrence? So that was, I would say, a little bit, if I'm very honest, that reflection of, okay, I really have to do something else with my life, and I have to change medicine, and somebody has to do it. And luckily we have lots of like-minded clinician scientists who see and feel the same. So there is a movement. So that's the reason why we established the Healthy Longevity Medicine Society, because one leg was in management, the other leg was really in research. And I did lots of studies with centenarians, but also with 20 or 30-year-olds, with middle age, with the propensity of longevity, and middle age with lots of diseases already. So while understanding why we age and how our body is behaving during our aging process, I thought, okay, now I have to do it and I have to bring it into clinical practice. How do I do it? And nobody has, I think, the recipe. On the other hand side, while having all the accumulation of knowledge and writing papers and having a H index which is rising, nobody is really being cured. So we have to be able to implement it into structures. And of course, it's a rising business. Like 100% of the population, if you call aging a disease, is sick. So others, of course, also see that, and that's why there are so many wellness clinics, so many anti-aging clinics, etc., which are great to have, but however, and that's a little bit my fear, it's not regulated, so I don't know what the quality is. And that was a little bit the second, next to my a little bit frustration, that need for regulation and defining what is good care, even if it's not medically regulated, but what can a person going to the clinics, what can they expect? So what is the return of investment, either of the time or the money they're spending to take drugs, supplements, to get tested, etc., in clinics which are already there. On the other hand side, what we can already buy on Amazon or on other providers. So who is actually be able to advise individuals what kind of supplements to take and which supplements not to take, and which, not only what, but also which dosage, frequency, etc., to have possibly health benefits. So, and again, there the society kicks in to do that. I would also like to see that medicine is kicking in there, and that's the reason why it's a medical society. Because in medicine, what I learned, but that's only my opinion because I grew up in medicine, we are quite well structured. We have physicians which are trained to do a certain job. And the job is being done most of the times by following guidelines. At least we have discussions and we give guidance to ourselves, and we give guidance to the health insurer what to pay for and not to pay for. And that's very important. So the society has three aims. The first aim is education. So what we are doing at the moment in the podcast, learn about the Healthy Longevity Medicine Society, for laymen, but also for politicians, for industry partners, and for physicians, and get it recognized as a specialty, longevity medicine, in, for example, internal medicine. I think secondly, I already touched on that guidelines are dear to my heart because I want to know what's best. And not everybody can look at thousands of articles and PubMed and summarize them. So we need that. And we not only need that for healthcare professionals, but we also need that for the layman. And we have to translate the knowledge into readable documents on websites, etc., that people know what they are doing, and that they can do a risk assessment themselves if they are taking supplements or they're going for a drip or whatever is being done. And the third thing is really that we harmonize what we are doing and we standardize what we are doing, we accelerate what we are doing in research. So I really look forward to a trial network where we can, across countries, across continents, can bring physicians together and researchers together to have phase 2B and 3 and 4 trials much quicker than we have at the moment, because we have so many boundaries by regulations and countries. We don't have the network yet. Maybe we don't have the trust yet, because the number of trials is not as big as in other specialties as endocrinology, oncology, etc. So we just have to learn to build a network and to work together and to standardize. So that's really why I founded with my colleagues the society. And it's growing and growing. So every week we have much more members than the week before. So it seems to be a movement. There's lots of interest.
Excellent. Excellent, really exciting, and I totally appreciate everything you just said there, because I think it's so refreshing, and to see sort of this part of the evolution of the space. So no, that's really exciting. You know, it's as you were mentioning, sort of synthesizing and distilling down the peer-reviewed literature. I have to say that of all the guests I've had on my show to date, you are by far the most prolific publisher I have ever seen. And I thought, you know, and the interesting thing is you don't publish on just one sort of hallmark of aging. You publish quite broadly. And what I thought it'd be very interesting to do is maybe now look sort of at a top line level at a couple of your papers, not just to show the scope of what you're involved in, but also how some of what you've been publishing on sort of trickles down into these new clinical models. And I thought it's a really interesting place to start, very apropos of what's going on in the world today, is your paper from 2018 October in Frontiers of Physiology, Repurposing Proteostasis Modifying Drugs to Prevent or Treat Age-Related Dementia, a systematic review. And in lieu of this amazing dearth of dementia interventions that we have, even in 2022, you at the time were looking at dozens of trials, looking at a range of repurposed substances, lithium, rapamycin, tyrosine kinase inhibitors, some supplement molecules, and so forth. Talk a little bit about, because, you know, repurposing is such a hot theme, and especially in this domain. Talk a little bit about the topic of repurposing, where it fits into sort of your medical, you know, practice, the way you think, and then obviously a little bit of your, you know, dementia is an important topic for all of us, but also for in your research program. Talk a little bit about some of what you found in this particular study.
Yeah, so the reason, if I'm very honest, to look at dementia, because most of the knowledge we had about repurposing of drugs was related to one organ in our body, and that's the brain, because this is really what we target to be. It's not only that we have to be able to walk and to talk, but we need a brain, and we need a little bit of cognition, etc., while we are aging. So the reason was really a pragmatic one, because I'm really interested in the aging process itself, and in all our organs and all our cells, and not just for dementia, because if we cannot walk, how can we talk and make sense out of it? So I think the integrity of our organ system is most important. While you're doing systematic reviews, it's very important that you have an outcome in the end, as you said, and to learn most, and then relate that also to other organ systems. So that's a reason why the primary outcome is dementia. Why is repurposing drugs so important? If we are looking at the aging process and how we could antagonize the aging process, there are three different domains prominent. The first is lifestyle. Okay, we can walk more and eat less, etc. So maybe we'll touch on that a little bit. But secondly, we can have supplements where we enrich what we normally would eat, or things which are not registered with the FDA or the EMA. But the third is very interesting, because I have, as a physician, lots of medications which I prescribe normally to my patients. So I know how to prescribe them with doses, etc. And I have a very good safety profile in myself, and I know what I should expect if people are taking it. So there was repurposing of drugs for new indication, which is aging, could be quite favorite. We know already why and how these medications work, and therewith we know how safe they are. Look, let's try that. So I think one of the most important repurposing of drugs studies is still TAME from near Basili, giving metformin to individuals who do not have diabetes. So with that analogy, we could give so many other drugs where we know how they work. For example, having something positive in the proteostasis. We know that the proteostasis is going to decline, so the proteins are misfolded in the end with higher age. And drugs as lithium, which we would normally give for psychiatric patients in much lower dosages, could actually help with the folding of proteins and stability of proteins, and therewith prevent the decline during the aging process. And there was also prevent the decline of cognitive function. So that's the entire idea. But we had a couple of other reviews, not about proteostasis, but insulin sensitivity, etc., giving metformin, insulin. So there's so many drugs. So my group really searched for drugs to actually trial then in humans. So we included lots of animal studies, including studies with Drosophila or with C. elegans, a worm, or mice and rats, etc., even chicken, and looked at, okay, what kind of proteostasis modifying drugs do we already have, such as lithium, which could influence the cognition better. And what is the translation, which is very important, into human studies? So we analyzed that, and there's lots of positive signals, especially in the animal field. If we then look at how many studies are really being published doing these trials in humans, they are much more limited and they're much more positive. So this already rings a bell in my brain. Like, why are all the studies in animals positive and so la in humans? I must just correct that in humans it was positive and negative ones. So maybe we have to do with publication bias, etc. But what these kind of reviews bring is a better understanding of the mechanisms and a little bit of the effect size, which organs to target. So we did the same for insulin signaling pathways and for others. So there we learn how the hallmarks of aging, so the mechanisms of aging, really interfere with organ dysfunction and how repurposed drugs could help. And one of the drugs, of course, high on the list, which we are going to trial soon in Singapore, are the rapalogs or the rapamycin. Normally we would give them to kidney transplant patients, but we know how well they're modifying not only the immune system, but cellular function, which could then end in a prevention of age-related diseases. And the strategy, how we choose what kind of next randomized controlled trials we do in my group at the University of Singapore, is that we first look at all the literature in animals and in humans. We summarize that, we do meta-analysis. And if there's a gap, we are going to kick in and do that trial.
Excellent, excellent. Moving from dementia now to your thought leadership in the whole area of frailty and sarcopenia. Next year in August 2019, you published a paper, again in Frontiers, Age-Related DNA Methylation Changes, Potential Impact on Skeletal Muscle Aging in Humans. And this one's also fascinating because you touch on, obviously, the epigenetics of muscle cells, but you also bring in another very hot topic nowadays, the whole area of the biomarkers and the epigenetic clocks. And then this also got me thinking, because you've gone, you also work in the clinic with patients that have sarcopenia, and thinking about, okay, I'm trying to remember my basic biology here, but there's that muscle cell, and then it becomes the tubes and all that, and the muscle has to form in a certain way, and you got to exercise it and so forth. I really thought this was a very nice platform, again, for sort of the continuum that you're focused on. Talk a little bit about this, and also just say a few words about the clocks, because I know, again, reading through the Healthy Longevity Medicine Society, a major part of that is sort of the understanding, the diagnostics, the understanding of how we are aging at genetic, epigenetic level, and so forth. Talk a little bit about this paper as well, as you would.
Yeah, so muscle as the brain is very important, and I think it's a little bit under-recognized, the human muscle. We have more than 600, and it should be the biggest organ in your body. So that's very important. And what I also like with the muscle is that it's modifiable. Look, it's very hard to increase the brain. But if you're going to the gym and you do resistance exercise training, you can increase your muscle mass and muscle strength and their function, and reduce the risk of not only falls and fractures, but also diabetes, for example. So it's the most modifiable organ we have. We appreciate, I think, because we have to do something to do it. I just went to a walk, so that's good with the dog. So I did my physical activity for today.
Yep.
But most importantly, of course, is why is that human muscle so flexible, and why do we lose so much every even day if we are immobilized? For example, ICU patients or immobilized individuals lying in bed, they are losing 10-15% of muscle mass in a couple of days. So it's so rapid. And what is determining the muscle mass and muscle strength and the increase of muscle mass and muscle strength of individuals? And I think that's so fascinating, and they are epigenetics, but the all hallmarks of aging kick in. And you just referred to one of the papers we wrote, because we know that the epigenetic makeup, which means on the DNA, there's on top methylated pieces on the DNA, which is called then epigenetic. It's on the genes, epigenetic. And depending on where the methylation dots are, that's dependent on what kind of organ you're looking at. So where you take the piece out of a human body. So the methylation is individual, it's different between the organs, and it seems that 1/3 of what is methylated, what the fingerprint is of the methylation, is the same in the different organs within one individual. So that's already good. Okay, so 1/3 is the same, and then you have 1/3 we have really no idea, and 1/3 is very different, and that's organ specific. So then of course the question is, it's an organ like muscle is very reachable, so we can take punch biopsies and take some material and actually see what their methylation state is, and if the methylation is different in individuals who are physically active or not. It depends on muscle strength or mass, depends on what you eat, etc. So because it's so easy to obtain, or relatively easy to obtain, it's still painful a little bit to take a muscle biopsy. It's so nice to learn of what is so specific about muscle, and then also to compare that to other organ systems, and then the clocks kick in. I would say there is a hype of building clocks in the last 5 to 10 years. A clock only means that the methylation state, an epigenetic clock here with, and the methylation state, how different that is compared to your peers of the same chronological age. So that's the first generation clocks. So how do you behave in terms of methylation in a certain organ from a different cell compared to your peers? Are you behaving methylation-wise a little bit younger or older? So do you have characteristics which are mimicking the ones of individuals who are much younger chronologically or older? And therewith we can give a biological age, and the biological age can be very different from the chronological age, and the younger biological age is associated with a lower incidence of disease. So the risk of a disease is lower. That's the reason why you are biologically younger. So then the question, of course, is why is it such a hype? And I think I contribute to that because in clinics, I would like to have a diagnostic tool to say, okay, you are 62, however, biologically in your muscle or in your PBMCs in the blood, you are 48 or 52 and whatever. That might help to please that individual because that individual is biologically younger. In clinic, it helps much more if you say, okay, you are 3 years older compared to your peers. So, and we can reverse that while, for example, prescribing certain exercises, lifestyle interventions, supplements, repurposed drugs, as we just talked about. So it is using the same information, but then linking it to a chronological age and to the risk of diseases. And that's what we call clocks. And we can build these clocks while using lots of information, for example, the methylation clocks we have, but we can also build a blood clock. So we take bloods regularly within internal medicine. Every GP takes blood a glucose, a creatinine, so looking at the kidney function, liver function, and all these numbers we now created to make clocks. So we can say overall, your body is functioning as a, and then an age, a biological age. So we are making now, by using the measures differently, we are making clocks, which we can then translate into clinical practice.
Excellent. Really exciting. Just a couple more here. I just, once again, to round out sort of the amazing scope of what you've been involved in. But I think this one is also, I mean, this is about a decade old now, but I think this really feeds into a lot even in 2022 now. And this is your 2011 paper in the Journal of General Virology, entitled Infection with Cytomegalovirus, but not herpes simplex virus, inducing accumulation of late differentiated senescent T cells in humans. And again, I thought this was fascinating because you're focusing here on CMV and senescence, and sort of senescence, immunosenescence, obviously a major hallmark of aging. Last year, I did an episode with Dr. Ruth Itzhaki at Manchester. She was focusing on herpes simplex and it messing with proteostasis and potential links to dementia. I'd love to say a few words about this, but also, the microbiome / virome is something that's sort of, I say missing. I mean, obviously it's out there, but we don't find it on the hallmarks of aging. We don't find it sort of in the SENS 7 basket, but it's extremely important. And it trickles down to a lot of this stuff. Just, I'd love to hear sort of your top line views on what we could be doing about the beneficial or the not so beneficial microbiome as part of this whole picture, because clearly it's impacting a lot of these hallmarks along the way.
Yeah, so first we have to recognize that they're influencing us, and that was the 2011 paper, where we really showed that if you're CMV positive, and it belongs to the herpes viruses, the CMV, like HSV, etc. Look, you chronically have it, so you don't know. So it's not like a blister at the HSV that you have it. So you don't know if you are CMV positive. Only if you are a blood donor, they will let you know. So that a virus being chronically present has such a detrimental, or has an effect so much on the immune system. Looking at the aging trajectory of individuals who are CMV positive or negative, that the ones who are positive have so much more differentiated cells, and that most of these cells at older age are against CMV. That's smashing. Look, it seems that our immune system is only really busy to keep up to date and engaged with CMV. And there is no cure for that. However, we also did lots of immunological studies related to epidemiology to actually see, is CMV really associated then with a higher incidence of cardiovascular diseases, age-related diseases, or even mortality. Because our thought process was, if CMV is so much associated with a very aged immune system, then it would also be much more likely to have, through inflammation, etc., to have much more age-related diseases and mortality. If we are getting all the data together of tens of thousands of individuals, what we found is that, yes, it is associated with cardiovascular disease, especially diseases, age-related ones with more inflammation. However, there is only a very tiny and by neglectable increased risk of mortality. So it seems that we learned how to deal with CMV being in our body. At least I know that I'm CMV positive, so in my body, and I'm dealing with it in a sort of homeostasis. And it is not giving me a rise in the chance of mortality, for example. So there is a balance. And I think what we should try, and that's what the field is doing, in analogy, we have so many different species in our body, either within our, hopefully not blood, because that will give us sepsis, but in our guts. we are living with, and there is a sort of homeostasis, and now targeting different species and how they could improve our health based on what we eat or how much we drink, what we drink. We even do not know how much we can regulate the microbiome, that the microbiome is living with us in a even better homeostasis and balance, as we showed very early days, as you said, like 15 years ago, we did the experiments with CMV. So it's really interesting to see, okay, what is harmful, what is for benefits of both, so the microbes together with our body, and where could we even more benefit from. And I would say we are touching really the surface of it. 10 years ago in clinical practice, I did even feces transplants when people were resistant to antibiotics, for example. So really extreme things, but which means that we already now know since a couple of decades how important it is. And now we have to find the balance, how we can improve healthy longevity while improving our communication with lots of very nice species living with us.
And improving the communication of selling fecal transplants, but that's a different topic for another day. But no, I really appreciate that perspective on it, Andrea. That was great. One last paper, then I promise we'll loop back to National University of Singapore. But I just want to ask, because I'm very fond of the whole topic of robustness and resilience, and you published this paper, Resilience to Cognitive Impairment in the Oldest of the Old, design of the EMIF 80-90 plus study, looking at what in these populations of nonagenarians makes them so resilient. What are the protective factors to neurodegeneration? Can you talk a little bit just about resilience? Because I think this is another area that I think gets overlooked a little bit in the sense of how do we obviously. We have the drugs and the interventions and stuff, but resilience is a little different. It's sort of coming from the other side of, how sort of the core of our genetics, the epigenetics and so forth, resist things happening. So talk a little bit of resilience, if you would, and what the EMIF 80-90 plus study was all about.
Yeah, so first of all, most of the times we describe individuals and we say, oh, this individual is not frail, is looking good, is frail, etc. But most of the times we are characterizing individuals, and that's also when we are seeing somebody on the street just walking. So okay, looks good or looks bad, maybe needs a new hip replacement or whatever. So we are judging based on a steady state and normal conditions. And however, that doesn't tell the entire story, because sometimes we are exposed to stressors, which can be a physical stress, and it can be a mental stress, it can be environmental stress, etc. And then we are testing resilience. And resilience is nothing more if you have somebody in the steady state or a cell in a body. So it can be groups of individuals. You bring a stressor, you actually see how that body, for example, is reacting to the stress. And that then defined as, is somebody resilient, yes or no? So in my early ages, actually, we cultured fibroblasts, and we were just looking how they were doing in the petri dish, and we couldn't find any association with a clinical phenotype. It was just a fibroblast and not telling us anything. While really stressing that system, these kind of fibroblasts with glucose or radiation, we exposed them to stress. And therewith we are tested the resilience. And while testing the resilience and dividing really individuals who were and cells much more resilient to compare to others, we were able to see the association with clinical phenotypes. So fibroblasts even crawling in a petri dish, not being associated with anything while being stressed. These resilient fibroblasts were associated or were coming from individuals who had a much better lifespan and health span, so less diseased, etc. Where looking at just crawling fibroblasts and then being stressed, which were much less resilient, these were coming from individuals already with disease, etc. So sometimes you have to stress the system to identify characteristics and to learn. So that's what we also did in our 90+ study, with the primary outcome, okay, what makes you resilient in your brain, that you keep your cognitive capacity active. So you still can think and walk and talk, you're socially integrated, etc. So what are the determinants of that phenotype, which is of course very, everybody wants that, to be not only physically active, but also cognitively active at a certain age. So we found, of course, that there's a huge link of the body to the brain, for example, with the muscles, but also with the heart function. So we now know that the brain is functioning in a network of other organs. And that's also the reason why I think that every brain researcher should not just look at the brain, but the brain is in communication with the heart, with the lungs, with the muscles, even with bones, etc. And that is all interfering with each other. And just making the brain healthy will not work, because you need the rest of the body. So we also looked at the immune system. So really, we were able to create a network to see what kind of environment does the brain need to age healthily, which means that you also have to keep the other organ systems healthy. But we also looked inside of the brain, because the brain is not just the brain. The brain is composed out of white matter and gray matter and different structures which are interconnected. And we said, okay, what is possibly the weakest link which makes or increases the resilience of brains? So, and you need, of course, the hippocampus, because the hippocampus is a little bit your storage of the brain, where you put down all the memories. Mm-hmm. And if you need them, you have to get them there. Yep. But also the motor cortex to make you move, or the frontal cortex, where expressions, etc. are, if I'm now sad or not, if I'm aggressive or not. So, and how these different structures in the brain are working together, and what kind of damage accumulation individuals have who are quite resilient or not. And we, of course, not only looked at the structures, but also looked at the function, while doing very sophisticated brain scans, where we were able to trace certain molecules in the brain and see what's activated, what's not activated. Because if you have it, it doesn't mean that you use it. Right. So that's even most important. And that's what we did with a huge European project, the AMIF project, where a couple of centers also recruited 90+-year-olds, and every of the center had a different task, which I really like in consortia, because then you can not do the same, but you add another piece of the puzzle to then have this nice picture what a 90-year-old really is, and how they are functioning, and what a resilient brain really means.
Outstanding, outstanding. I really appreciate you taking time to go through those 4 papers. And as I said, I really wanted to sort of lay the groundwork to show sort of the scope of what you're all about. We've talked about epigenetics and resilience and the microbiome and repurposing and all sorts of exciting topics. Obviously, this lays the groundwork for why you are now, with Brian Kennedy, leading this amazing healthy longevity program, National University of Singapore, also the translational research program. Take us through it a little bit, because obviously, in addition to research and practicing medicine and running the Medicine Society, you have had to raise money and set up this whole amazing hacking aging system. Talk a little bit about this journey. Sort of talk about, obviously you're in the Netherlands right now, but you get back and forth to Singapore. Talk a little bit about Singapore and its interest in being a sort of a world-leading epicenter for this work. Maybe a little bit about the Lean Foundation, where you raised your money from. Take a little bit about the history of what went into setting up this new, really cutting-edge initiative in Singapore.
Look, I think, of course, there are lots of cities and universities to do aging research, but I have never seen such an engagement and commitment, I would say, from the university to make it happen. So the first things to the deanery, etc., to really make it happen, to the Faculty of Medicine. It's not very often that you speak to either hospital managements or the managements of universities that they really understand what you're talking about, and they are even faster in reading geroscience articles than you are. So, and that's so fascinating. And so the National University of Singapore really makes it happen. Secondly, there is an ecosystem in Singapore of lots of startups. There's lots of movement, lots of innovation, lots of interfering activities, which also help to engage with the university, but also to engage with public and with industry partners. Yeah. And next to that, there are luckily foundation sponsors like the Yen Foundation, which really think, okay, this is the way to go, and we want to fund it, and we want to help you in raising awareness. So it's not just the money, but most importantly also that we have programs for outreach, that all Singaporeans should know what geroscience is and what our aim is. So that's a very special ecosystem. The most important, that's a little bit the cherry on the cake in Singapore, is that politicians are very interested, because as in all countries, we are aging societies, and the fertility rate is also quite low in Singapore. So we really work together with the politicians, with the MPs, to make it happen, to see, okay, at which stage is the research, what is translatable into clinical practice already, and how can we evaluate if it works or not. And what is so important is that the vision is not a short-term vision, but it's a longer-term vision, because aging is a trajectory. So we will not have great successes, maybe in trials, but not implementing it into clinical practice in the next 1, 2, or 5 years, because the outcome will be visible in 10 or 20 years. So while having these rigorous conversations of, is Singapore ready to implement certain things, that's what we are doing with not only the councils, the medical councils in Singapore, but especially also with respected politicians in Singapore to make it work. And I haven't found that ecosystem where all the partners are really working together. So what's the aim of the Center for Healthy Longevity? It's very easy. Only 2 big aims. The first aim is to find valid, accurate diagnostics for the aging process, which means which clock is most accurate, which can be implemented into clinical practice. And we also, while doing so, are really looking at the pathways of why we age in worms and C. elegans. So Brian Kennedy is doing that. And once we have a hit, we bring that quite easily. That's my specialty, to humans. Yep. And we can test it. And we also test if, for example, such a clock works in 20-year-olds or 40-year-olds or 60-year-olds, but maybe that clock might be different at different age groups, because the clock might tick differently in older individuals, but it might also tick differently in different ethnicities. We don't know how different ethnicity, races, etc. age, and also clocks might be different. So that's the reason why we really invest also in cohort studies, also longitudinal cohort studies, to include the diversity of the population, all living in Singapore in the same 40 by 20 kilometers, or in Asia, which is, I think, very important to really understand the biology behind aging, and then transfer that and make clocks out of it. The second one is, look, I would find it quite unethical to just measure something without interfering and without intervention. So the major pillar where the most investment at the moment is going to is to interfere with the biological aging process of not only C. elegans and all the rats and the mice, but especially also with humans. And what we achieved at the Center for Health Longevity, we have a preclinical team and we have a clinical team, and they communicate. That's most important. So if we find something in mice, we will have, of course, beforehand also meetings to say, okay, what do you see? Can we translate it? Can we really, based on these results, make the first trial already in humans? And once we have the human studies, can we take the biopsies? Can we link back to the mechanisms, and can we bring it back into the animal models? So making it as a circle to make it better. And we have 3 different domains. First is the lifestyle domain. So thinking not only you have to move more and eat less, right, but making it very specific, what kind of diet, most healthiest diet. I think it's very, very powerful. And we forget most of the times that there are lifestyle changes which can have a huge effect. Secondly, these are supplements like alpha-ketoglutarate or spermidine or quercetin or look, there are so many. And thirdly, as we already touched on, that's the drugs, and especially repurposed drugs. Yeah. But while doing and having that deep link with the preclinical team, of course, also the new drug candidates, which we will bring in phase 1 and 2 studies, whereas the repurposed drugs will much more go into phase 2B and 3 and 4. Next to that, to just additionally, we have 2 big projects, and that's the health district in Queenstown. There is, within Singapore, there are districts where people live, like hundreds, thousands of people. And we are now doing research in one of the districts where we actually know who is living there, but how people are living, what the environment looks like, how much steps they take, how much sun there is, how much noise there is, where the normal groceries are being bought. Mm-hmm. So we have lots of detail, and we have with the GPs, we have now a network where we can actually track the health of these individuals. And this is the platform where we do phase 4 studies, because we're already tracking these individuals in cohorts, and then we can do supplement studies or lifestyle interventions, or at a certain time also include them into repurposed drug trials on a much bigger scale, because we have already the information. The second thing of that more outreach of our research is that we will open the first publicly funded healthy longevity medicine clinic in one of the hospitals in that district. We are going to open the first clinic, like a polyclinic, where we see individuals and expose them to geroscience, diagnose their biological age before they are sick, and implementing the care already in the hospital system.
Outstanding, really outstanding. One thing, as you were going through that process, you reminded me of one other thing I just wanted to ask you about, because I spent most of my career in the pharmaceutical industry, and one of the things that was sort of anathema, let's say, back in the early day, was the topic of combinations, and that, you know, it's great to study things when you combine them, but it takes forever. We like to study drug A and then drug B and then drug C, and ultimately put drug A, B, and C together. And we have, as a result of that, amazing HIV treatments nowadays, chemotherapy cocktails, and so forth. There seems to be sort of an underswelling in the longevity community that it'd be really nice. It's great to study metformin and rapamycin and alpha-ketoglutarate. Be nice to study them together at some point. That doesn't take 30 years to do it. What is your position at the new center on how one goes about combination interventions? Because I think there's sort of an understanding that's probably useful at some point in this whole dynamic. And I know people will say, well, how do you study pharmacokinetics of combinations or pharmacodynamics and all that bit? But I'm interested in outcomes. So what's your perspective on this?
So, and not much in papers, because the outcome, so you just have to write it down. Right. So what the strategy is, we have the randomized control trials in parallel. So we have one control, 40 to 60, for example, individuals, healthy, who are exposed to control pills. Then we have the actual compound, the supplement, for example. But we have different supplements in parallel, and we are testing them not only in different dosages, but also different compounds, which means that we can then also, because we are doing it at the same time, we can look at the effect sizes of the different compounds. Now that's the first step, because if you're looking at literature, it's very hard to do meta-analysis, even in NMN trials, because everything is different. So the first step is, what is the effect size, comparing the effect sizes of different drugs, then looking at the mechanisms or supplements, then looking at the mechanisms which could actually be additive or which might not be additive, and adding them into that scheme of parallel trials, because then you also know what's going to work and what's not going to work, and which ones have additive value and how much additive value there is. And that's absolutely what we are doing, and then have a triple regime, etc. I think what's most exciting is to bring that multi-pill or multi-supplement ingredient based on the personal characteristics of the biological phenotype of that person, so make it personalized. I think that's even the next step. So we will do lots of post hoc analysis to say who was a responder for APG, who was a responder for fisetin, spermidine of NMN or NR, who responded based on what biological phenotype, of what clock, of what problem in the cell, and then make it even more specific. And then you are reaching the theme of personalized medicine. So it has to be adapted towards what's maybe not wrong, but dysfunctional in that cell and cellular systems in certain organs of that individual, and try to fix that, as we do also in oncology, for example, because oncology in the last 20 years really changed. Now, everybody has a different scheme of chemotherapy, etc., based on the molecular basis of that cancer that person has. And that's my aim, to bring the healthy longevity medicine into that personalized trade, or at least clustered trade of therapeutics.
Outstanding. Really, really refreshing to hear this, Andrea. I mean, it's really remarkable what you're putting together there.
It's just copy pasting out of things which others already did and other specialities. It's just learning and observing and repurposing.
I mean, there it is. I mean, it's as I said, it's very elegant and refreshing to see this happening. I take my hat off to you if I had one on. So I mean, I've seen you recently at a lot of the longevity conferences. Obviously, you've been in the news a lot based on the News Center. I saw some videos of you with the ministers and everything on the stage. Anything else that I missed that's happening for the rest of 2022? Things that are going to be coming up in early 2023. Other conferences you're going to be at, places that we can meet you, talk to you, see you present. Anything else that I haven't touched on, please take the floor.
Look, I would say just be in contact with me or follow me on LinkedIn and in Twitter. I'm better in LinkedIn. I don't understand Twitter really. So, I'm bad in that. If somebody is listening and teach me how to do Twitter, please.
I'm not that good at it either.
No, but follow the normal news channels, read articles, and I think most importantly is that let's take this field seriously. And let's bring evidence into the field, and let's do that together. So if you are looking for collaborations or whatever, please reach out, and I'm happy to help to build the network.
Excellent, really excellent. For everybody that is going to be listening to this particular show across the different podcast networks or watching on our YouTube channel, again, you've been listening to Dr. Andrea Meyer, Professor of Medicine, Healthy Aging, and Dementia Research, co-director of the Center of Healthy Longevity, National University of Singapore, also founding president, Healthy Longevity Medicine Society. We will put links to Andrea in the bio of the show. Andrea, I want to thank you for taking the time out of your schedule to walk us through this amazing story. Obviously, thank you for everything that you're doing there and continue to do in Singapore, in the Netherlands. And as we like to say on our show, thanks for helping to create a better tomorrow for so many people via what you're doing. A really very inspiring story.
Thank you so much.